Yeah, you can go over here. Or you can use this mic if you like.
Good afternoon, everyone. My name is Nick Orchard. I'm a second-year PA student, and this is actually not my presentation. This will be Craig and Jasmine's. I had thrown back and forth the idea of doing a PowerPoint, and I let you guys all down. You'll have to listen, maybe shut your eyes and pretend, but this will be probably good practice for, I don't know, the days when PowerPoint's not available to us. I'm one of three second-year students who is involved in this project. My classmates Christina Searles and Kristen Monks are both on rotation on the western slope, and just due to scheduling and all, they were unable to make it. So just as a kind of an introduction, as second-year students, we're traveling all throughout the state. Myself, I'm currently down in Huerfano County, in the city of Walsenburg. So I drove up late last night in order to present this, but that's part of what we do and how we're involved in this this business of working with rural and underserved populations. The title of our project is called Behavioral Health Access for Huerfano County, Colorado. Huerfano is a county that is south of the city of Pueblo. It is in an area nestled between the Spanish Peaks and Mount Blanca. Ironically, the Spanish translation for Huerfano is orphan, which in many ways explains how some of the counties, the areas in that part of the state geographically seem to be viewed in terms of finances and access, which we'll discuss some more. The root of this project that we decided to work on is focusing on the access to behavioral health that exists in that area. The town of Walsenburg is the county seat, and it has a population just over 3,000 people, and it is considered the hub of the entire county. If you consider all of the other residents, the population comes to just over 6,500. So we're looking at a population that would be probably just a square mile of Lakewood, Colorado. However, the needs and the requirements of those individuals there in terms of healthcare are the same as anywhere else. However, you don't have St. Anthony's just down the road. You don't have mental health services. You don't even have the police and fire services that exist here. So taking a step back and just discussing behavioral health and the challenges that exist at the national level, this is not a problem that is in any ways unique to either Colorado in a rural or urban setting, but exists throughout the nation. Behavioral health, mental health has for many years been stigmatized in terms of how it is looked upon by the rest of general health care. That's not necessarily good or bad. It just has been an extension. It's existed on the periphery, and it's been within probably our lifetimes as students that we've been able to see a change, a transition towards behavioral health being drawn into the general health population in terms of finances, in terms of access. The problem still exists, however, in getting finances and access to rural areas. Along those lines, the challenges to mental health that exist, it's not something that can necessarily be easily diagnosed by, say, a general healthcare practitioner or primary care provider. We'll have some difficulty in diagnosing, say, schizophrenia or bipolar disorder, whereas an individual coming in with gout or perhaps a knee injury, that's much easier for those providers to work up, diagnose in that setting. I'm speaking from experience, and I think the experiences of my classmates reflects this. I've seen very frequently healthcare providers that are primary care that need to refer individuals who have pretty straightforward, simple mental health concerns, they get referred to psychiatric services because these providers don't feel comfortable taking care of individuals who have, say, schizophrenia. It's a specialty just like anything else, whether it's gastroenterology or rheumatology. A specialist comes in, usually makes a diagnosis, comes up with a line of treatment, and gets the person stabilized. So the question then comes up, if there is no psychiatrist, no psychologist that exists in a geographic area, and as a sidebar, Orfano County, hint, hint, the purpose of our study was, how can we start to provide those services to someone? If you were to look at the specialty list that does exist at the hospital in Walsenburg, they have orthopedics, gastroenterology, nephrology, urology, women's health services, but there is not a direct line of contact for patients to see a psychiatrist. This becomes a big issue because a large portion of psychiatry will show up in a crisis situation. Patients don't often come in and say, hey, I've been feeling like I've been down for the last few months. I think I need to be on some medications. It typically instead evolves from an emergency department visit, a contact with law enforcement, or perhaps in a roundabout way, family getting involved. And if you don't have any access to care because there's no psychiatrist that exists in that county, let alone emergency access to care, you're really setting yourself up for some difficult situations. So I'd like to talk about what does exist right now and what we would like to see exist in the future. As far as Orfano County is concerned in psychiatric services. As it stands right now, there is one hospital in the county. It's called Spanish Peaks Medical Center. It has an emergency room with 24-hour care. It does have an admission unit that does take acute care. However, any patients that might require intensive care, critical care services will be flown out by helicopter or sent by a ground unit if it's inclement weather. There's also a primary care service with 7 providers that exists on the campus. They are primary care physicians who also work in the hospital and round on the acute care patients. And then there is a 100-bed long-term care veterans home that exists there. The next town over, La Vida, the second largest in the county, has just under 1,000 people living in it. And there's a clinic that's been set up through Spanish Peaks Medical Center that exists there. 2 providers work out of that clinic doing primary care, but there's no emergency services that exist there as well. And then in the city of Walsenburg, there's what's called an outreach clinic. This is a safety net setup that was basically designed at the state government and the federal government level to provide critical access care for patients who either don't have the financial access to getting such services or don't have a regular primary care provider. So such things that this outreach clinic can provide would be early screening and prevention programs, either for something like high cholesterol or heart disease. They also provide pregnancy and sexual health programs just to get people basically the initial care that they might need, and then they're certainly there to provide access for substance abuse problems as well. Now, 3 different clinics exist, but again, there's no psychiatry, there's no psychology that exists there. As it works right now, if a patient is requiring such services, there are 2 options. One is, in the immediate sense, they get stabilized in the emergency room and then they get sent out. The options for transport are usually Pueblo, but it's easily a 45-minute drive at best. But under any type of conditions like today, it could easily be an hour and a half to 2 hours. It gets very windy there, so helicopter flights are not always an option. In sending someone to Pueblo, now you have the concern that I have a resident who exists in the county, lives here, has their family and their job here, but I've now sent them away to another town and to a provider they don't know. So that sets up a lot of challenges, especially for someone who is dealing with an acute psychiatric concern and may have trust issues with the healthcare system as it is. Sending them somewhere foreign to see someone who they don't know is often a big concern or challenge for them. And then the second option would be to keep that person in the physically, geographically in the town and just get access of care to them. As it exists right now, there are a couple of programs which have used technology to marry the patient with a provider, where the provider is physically set apart, usually in Pueblo, but perhaps also in Colorado Springs. There are some psychiatric programs in which a patient can sit down in front of a computer and Skype with a provider in another city. This is probably a good situation for either a consult, maybe physician to physician, provider to provider, but when you're trying to set up a relationship between a provider and a patient who's having difficulty, this Skype situation doesn't always work. And I've gotten some firsthand experience with talking to patients who said it just seemed like such a bizarre setup that they were just talking to a computer about their difficulty sleeping and their hallucinations, that they couldn't gain the appropriate care that they needed. So I'd like to talk to you about our proposal and how we'd like to mitigate all of these problems. After doing a bunch of research, my classmates and I decided that the biggest hurdles that we needed to overcome started first and foremost with the financial hurdles of how can we get money to make change, create change, and create a beneficial environment for these patients. There do exist a number of programs at the federal level. In particular, the United States Department of Health and Human Services is interested in both research and grant programs to get money to rural areas. The state of Colorado also is involved in that. One such program is called Critical Access Care, and it's a nationwide program that gets emergency services and acute services available to certain areas. And that emergency department in Walsenburg that I was describing is one of such programs. Similar to that could be a psychiatric service. We'd like to set up a program in which providers that already exist in Huerfano County have the opportunity to treat patients who they already know in an area in which both the provider and the patient are familiar with, and implement the correct services that they would need. So if we were to take mid-level providers, which are physician assistants and nurse practitioners, and basically get them the training, the experience, and the confidence that they would need, as well as some tools for when they get into trouble, we can then provide an environment in which people have psychiatric services right there available to them. Our goal is to take two practicing providers and get them trained up to speed in a program that already exists. Let me get the official title here. The Association of Physician Assistants in Psychiatry offers a program in which they will train on an annual basis physician assistants to be able to function in the psychiatric environment. The training itself is actually fairly straightforward. It's on top of the training that a physician assistant would already have, and it's coupled with primary care, so it works very well at meeting the two halfway. The training would be on an annual basis. It would involve room and board, airfare, as well as membership to this association. And in order to get two people on board, two providers, we're looking at a cost that we came up with of $3,070, which is a remarkably small amount of money for what two providers can then give back to their community in terms of psychiatric care. These providers would work just as they are now as primary care providers, but they would be able to schedule patients to come in who have issues with depression, either primary depression or perhaps postpartum depression, bipolar disorder, schizophrenia, anxiety, even substance abuse. The benefit of having someone there is that they could handle, say, 50% of the problems that might come in the door. If that patient needs a higher quality, higher level of care, then they can be sent to the main group through which these PAs work with. The process has already been started. The physicians group under which the patient is receiving care is already familiar with the patient. It basically would then work like an in-network referral. This is very important, like I addressed earlier. There are issues when patients get transferred to a different facility, don't know who they're talking to. That provider doesn't know that patient, maybe didn't even get the paperwork. Simple things like that, even in this computerized world, can be a huge hindrance upon care that's provided. As long as this program exists, we would do continuous summaries of the services, both at the provider level and the patient level, and then we would work to have an outside, basically independent review of the process to see that it's meeting standards of both the Physicians Assistant Association in Psychiatry, but also the APA, the American Psychiatry Group. So these surveys would exist at the start, the initiation of the program, and basically outline what sort of opportunities exist for patients. We would do then a 6-month and a 1-year follow-up as well, both with the patients and providers, in order to see that we did have an improvement in access to care. But we also want to make sure that the care that's being provided is the highest level possible. We don't want to create a solution to a problem that looks good on paper and maybe meets all the requirements that, say, the federal government has for receiving money. We want to actually make sure that the problem is addressed. There are a couple of stories that I just wanted to share with you which help to motivate our decision in focusing on this project. I'm not going to get into very many details, and I won't share names because in healthcare we won't do that. But these are real patients that actually do exist that I had the experience to work with. One was last summer. It was a gentleman in his 20s who came into the primary care clinic with concerns for anxiety. He had a history of substance abuse, specifically with methamphetamines, and was trying to keep himself off of drugs. He recognized how much of a concern that those were in leading into anxiety and also possibly into depression as well with this gentleman. The provider I had worked with at that time had seen him 4 different times for anxiety in the previous 2 months, and he had been on 3 different medications for his anxiety. Nothing was working. The medications weren't helping. His time in encountering the physician weren't working for him. He'd get a 15 or 20-minute appointment, which would often go to 45 minutes because he had so much that he felt he needed to talk about. My physician supervisor, his goal was to make sure that this patient was safe when he left the clinic until the next time he came in. There was no resolution of his anxiety. There was no long-term goal of developing any sort of care plan for him. It was purely just basically plug the holes on a ship that was already sinking. So this young man was sent to social services at the hospital, which only exists through the emergency department, but they have recognized there's a need. So they took him in and got him set up. He was the one that worked face-to-face with a computer doing a Skype interaction with a psychiatrist that was in Pueblo. He said, he's the one who told me that it was such a bizarre experience he didn't think he could access the level of care he needed because just simple things you don't think about, but trying to communicate via a monitor on a computer, you lose inflection of voice, volume modulation, you don't get to see the mannerisms of the person you're talking to, body language is lost, and in discussing psychology, psychiatry, all of those things are pertinent to a provider's ability to take care of that patient. Ultimately, we had to send him out to seek care in Pueblo, and that was a significant challenge for him because he has 4 children, all of whom are, I think, under the age of 6. So he had to find basically an entire day in which he could go. His wife would stay home with the kids. He had to take off of work, and then he had to find a way to actually get to Pueblo. So I think it would be easy to find these kinds of situations as academic or perhaps situational and anecdotal. I know I just told you an anecdote, but it's a real one that exists. And we chose this topic in this forum in order to address a problem that we have seen, unfortunately, not just in Walsenburg, the town of Walsenburg, or the county of Huerfano, but throughout other different areas. I've had the opportunity to work in Fort Morgan, Rifle, Del Norte. I'm headed up to Leadville later this spring, and I can honestly tell you that such problems exist anywhere in rural and underserved areas. But it's not just geographic. There are areas inside of the city of Denver in the suburbs that also have a lack of access of care. So our hope at the very least is that just acknowledging this, putting this on paper, and putting it into your ears, even if they don't stay there, this information will help all of you who are going to be future providers to recognize that this is an ongoing issue and one which we will continually need to address. Thank you. Or you can text me. Facebook.
Good job.
Hello. All right, good. I'm Craig Wood, and this is
Jasmine Wells.
we're second year PA students. We did this project. It's really actually what it technically is a feasibility study to see the interest level for establishing a healthcare clinic in both Otero Junior College and Trinidad State Junior College.
Other people that worked on this was Grant Nichols and Crystal Zitterkopf, who were unable to make it today as well because they're out on rotations.
So as we kind of talked, it's kind of a feasibility study. So we wanted to see what the interest level would be in just establishing a health clinic like we have at Red Rocks at junior colleges that are more underserved areas. So Trinidad State, Colorado, or Trinidad State is in Trinidad, Colorado, and Otero Community College is in La Junta. Both of those are kind of in the southeastern corner of Colorado. They are separated from by about 80 miles. In order to make it kind of a feasible price for the students, we are suggesting having one physician assistant travel between the two campuses and rotate different days that their health care is available. It could be different weeks. That's yet to kind of be determined. But to kind of blunt the cost to the students, we just have one provider for both facilities. And that was kind of the genesis, was to bring on, because they have smaller student populations, bring on a couple different colleges and put them together that were in a geographical location.
Background and significance of this: college students are more likely to be uninsured than any other general population. I think that they're largely overlooked as an uninsured population. Of course, college students can stay on their parents' insurance up until the age of 26, but this is at the discretion of their parents to keep them on and keep paying. So often it's not the case. And also, many college students live on campus, and it's a convenience thing. They may not have a car, and they're at campus anyways. This gives them a way to just swing in, get their health checked out, get something that maybe isn't high priority on their list, and be able to be seen. 13 of the colleges in the Colorado Community College system, there's only 4 that have health clinics currently. So our goal would be to implement 1 or 2 in 2 of the colleges, and then hopefully someday the others will get on board and implement it as well.
Okay, so our specific aim was, just establish the interest for each college. We modeled our kind of plan after what Red Rocks Community College accomplished. So it was put to a vote of the student body through Student Government Association, and it was approved to have a tuition increase or a fees increase semesterly, yearly, to help supplement the cost of the community clinic here, or the student clinic. And so in order to do that, you have to basically have all the students on board and to say, hey, this is something that we're interested in, this is something that we want to fund, this is something that we back you, and we're behind. So we really want to see what the interest level is within the student population of both junior colleges. What kind of compounds the problem is that both colleges have to be on board for this to work. And so that's why we're asking for funds to put a study together to see what the interest level is. And I think in order to do that, you have to do it the right way. And the right way is having specs, having cost, having everything out there on the table. That way they know what the costs are going to be towards the student. Most of you guys are students in this room, so you understand what cost means and what convenience means. And we really wanted to go out of the way and kind of spend more time on that. And so that's why we're asking for funds to kind of fund this feasibility study.
And also part of it, we need to determine how many of the student population, or what the student population has insurance. Maybe there happens to be a high insurance population among there, and then this wouldn't work out so well. But if there is low insurance, there would be a higher desire for it. Also, perhaps students don't have insurance, but there's just not an interest for it. They don't want their student fees to be increased for one of these. So that's part of our aim to look at as well. Our specific aim number 2 is to determine the infrastructure and staff costs associated with implementing and maintaining it. Again, as Craig said, due to the smaller populations, it would work best to have one full-time PA that would rotate in between part-time at the schools. So yeah.
And I think when we're dealing with this population, you pulled some numbers and basically said that college students are the most underserved population. You're generally the most healthy, but you also have to think about communicable diseases, as Nick alluded to, mental health issues. I think that if a lot of mental health I guess, abnormalities or, schizophrenia develops in the college age population. So if we can kind of get them on track early and keep them from, or even bipolar type patients, keep them from going manic or doing destructive things in their lives early on, and maintain kind of a level of care that's higher than kind of standard to what they're used to in this area. I think it was kind of another specific goal that we didn't really put on our PowerPoint presentation, but it was something that we talked about, and that's a reason, the genesis for this idea. So as we talked, our 2 institutions, demographics, at Otero, there's about 1,823 students. 916 of those students are full-time. 907 of those students are part-time. So you basically have a half full-time student, half part-time student. And I think our demographic that we really want to target is that 907 part-time students, because they're probably working part-time jobs to do part-time schoolwork. So that could be a population that is at most at risk and who would be the most underserved of the school population. Trinidad State, it's almost exactly the same. It's half and half. So we really wanted to target those part-time students and make sure that there was some health care available to those students. So we're looking at a total enrollment between the 2 schools of around 3,700 students. It's variable semester to semester, but average. The uninsured rate, just the non-student population, for Otero County and Los Animas County is around 17%. That's a pretty low health insured population. So our kind of thought process is that this is a pretty uninsured population, so their students are probably even less insured, if that makes any sense. So.
And touching up what Craig was saying about the mental health as well for students, just for clarification, what the scope of the practice largely would be your general checkups, well woman exams, immunizations, minor procedures. I know that every PA student in here had to have a bill of health to be able to start, and we all have to have insurance as well, but how many actually use the health clinic out of ease and convenience? Probably most of you. Okay, so the research design and method will be using survey-based. We haven't decided on what kind of survey, email, it could be out in the hallways, it could be phone surveys. Phone surveys have shown to be the most effective, but very time consuming. So we would check for health insurance coverage, interest in student-funded health clinic, and the need for it. All information would be collected anonymously. And also we proposed giving away iPads just for more incentive of, okay, if you come and do this survey, you may have a chance of winning iPads.
College students like iPads, I guess. That's what we came up with. So these are kind of rough estimations that we talked with John and Jane Steen, that's actually one of the PAs up in the clinic here. And she kind of gave us some ballpark numbers of what the figures would cost to run a clinic. It's kind of, we're piggybacking these numbers for what the cost is here, but it's not specifically the exact cost for a yearly maintenance here. And really, this all depends on what kind of space is available at the school and whether the school is willing to give up a space to house a clinic and what the renovation costs are. So this is really, really ballparked, but it's one of those put us in the kind of ballpark, if that makes any sense. So renovation and construction of clinic space, roughly $100,000. That would be at each school. Equipment costs are not as much as I expected, around $15,000 for startup. Medical and office supplies, $10,000 a year. Medical director's salary, we're proposing to staff the clinic with a PA. So you would need to have a physician that would sign off on all those charts. That reimbursement cost would be roughly $36,000 a year. That could be a bargaining point too, as well, so it doesn't have to be, that's not set in stone. The PA, we are proposing to be $75,000 for a salary a year. Also, travel costs have been put into that, so it's kind of 75 to 82 with the travel costs. 2 medical assistants, one being at one clinic, the other being at the other clinic, or vice versa, split the salary, around $35,000 a year, and a clerical assistant to do scheduling, $15,000 a year.
So what does this mean? Startup costs are around $230,000, which is quite a bit, but we propose to have that funded through health grants. And annual costs would be around $190,000, and this would be obtained through a $50 student fee increase per semester. $50 a year per year. So $25 a semester. And if there's any difference in between there, again, propose an annual grant to offset the costs. For our research budget itself, it'll be about $2,000 for print services, $2,000 in travel. Architectural consult and design will be the biggie at around $10,000. iPads, overage costs, and the total budget would be around $20,000 to do this research study.
So this is kind of a generic timeline of how we feel like it should go, kind of. I know there's a lot of paperwork and there's a lot of wheels that have to be in motion, but if this were to be completed, we'd like to have a questionnaire done and approved by November 2015. December, try to survey the students. This is always a great time to do around finals because everybody's really concentrated on doing surveys and not on studying for tests. We'd like to present the results and start getting the ball rolling on the feasibility, if this is going to work or if it's not going to work. And then kind of depending on what happens in January, February, March, April, everything after that. So we really did use a lot of help and input from Jonna Jane Steen, so we want to thank her for her help and time that she took out of her day. And hopefully there's interest. Thanks.
Can we get another round of applause for both presenters? They did such a good job. And so now we are going to open up for questions and comments. Please do wait until you have the microphone to ask your question or make your comment, because we are recording this session for posterity's sake, and the mic is feeding directly into the recording. So,
Nick, I was just curious if you had spoken with the providers in that community. Like, are they really strapped for time? Do they have the time to maybe expand on what type of care they give?
That is a great question, and the answer to both is yes, that I have spoken to them, and no, they don't. I think that part of the challenge in any healthcare environment, so far as I've seen, is that you're constantly trying to maximize your time and financial gain, not because we're trying to make money, but just trying to make ends meet, and the clinic has to stay open. And so the number of patients that the providers in that area already are seeing is probably at their maximum. For an hour, that's 1 every 15 minutes. That involves your history, your physical, and then all your paperwork. So most of those providers are staying till the clinic closes at 4:30. My boss usually doesn't leave before 7:30 at night just because he's doing so much work. The other challenge is that psychiatric services are very time consuming from a provider standpoint. You can go to a once a week or twice a month appointment with a psychiatrist and have an hour, or basically 50 minutes, for which that provider is one-on-one talking with you. To gain such access to a general health provider, primary care, I don't know. Dr. Whitwer, how much would you charge for that? For your time? As a primary care provider, just to provide psychiatry, I think would be very challenging. So, and also, just to be frank, because this is something I'm interested in, I do ask providers. I asked at least my boss on in a formal question, but also a couple of providers. A, do you have the interest in doing this? And B, do you feel like this is something you can actually do? Because even if you studied psychiatry in medical school 20 years before, that doesn't mean that you're able to provide clinical care for a patient.
Okay. Next question or comment?
Actually, I have two that are kind of related in regard to Otero and Trinidad. Have you been in touch with the administration there, and is this something that they would like to see? And the second one is, do those campuses currently provide any type of mental health counseling that could be piggybacked upon?
Yeah. That's a good question. So I'll answer the first one in saying that we have not discussed had any discussions with the administration of Otero or Trinidad. The second, I will preface by saying I'm not certain if they do. I'm sure that there are counseling services. They don't.
No, they don't have any.
Counseling services. I know at Red Rocks we do, and that was limited in the scope of practice for what the health clinic can do here, is that because they have counseling services here, that they don't do counseling services at our student health clinic, so they're just referred to those counseling services here. So once again, a lot of wheels need to be set in motion for this to be done, and done right. I think done right is probably the first and foremost thing on that. And so, feasibility, we want to get some money before we can start running around because we're poor students.
And notably, the Colorado Community College System, as a group themselves, this is their long-term goal, is to eventually see student health clinics in the community colleges.
I've got a piggyback question on that, and this might be outside the scope of what you studied, so if you don't have an answer, I'm sorry for putting you on the spot, but I'm curious to know what percentage of the Red Rock student body uses this health clinic, and as a corollary question, are there any studies that have been done of the current health clinics and what percentages of the student population are making use of them, et cetera? Do you know what I mean? Because that seems like good justification to bring back to these other schools and bring it in, right?
That's a great question. And I wouldn't know exactly percentage-wise because I think there's some ethical things that go in with that to say, every student is using this or every student is not using this, and what are they using it for? I think you can probably put people into boxes and say, they used it for mental health or they used it for, cuts and bruises. And the simple question is I don't have concrete figures on how much it's used, although it has been utilized by the student body, and there have been, we talked to Jana about that.
So she said roughly 20% of the students use the health clinic here. So quite a bit. And there have actually been some very interesting studies done. I unfortunately didn't dive into them greatly, but there are some interesting studies out there that promote that student health clinics are very beneficial.
Great. Okay, anybody else? I have another one for the first presenter, actually. Let me find it. I was actually impressed by how inexpensive your plan was. And a corollary to that would be, again, similar to the question that he just asked to the other presenters, have you thought of trying to get the word out about your proposal? Because it is so inexpensive and it seems like such a great program. When I read your fuller piece, and I do recommend to any of you who enjoyed what you heard today to pick up the journal or read it online, read their full piece, because they give a lot more information and they're beautifully researched projects. So I do recommend you read the whole thing. But in yours, again, the massive benefit you would get for so little money, and who was the program offering the PA training in psychiatry? What was that?
That's the American Physician Assistants in Psychiatry.
Yeah, that sounded like a really great program. And so a second question for you would be, do you know anyone, or have you yourself had experience with that certification or program, whatever it's called?
I guess I'll start with that last question. Just we're right there. No, I haven't personally. In fact, this was part of our research, was to find out what is available. I think that the access to psychiatric groups at the physician level is probably better known. And I don't know if this is a newer group, if that's part of it, and they just haven't become quite as well known. But it's something that's absolutely, of interest to me. That's a good question. I don't even know where to begin with that. It would, I guess, just start at their website and go from there. It's a good example of how there's basically just a bare minimum that exists out there right now that I can't even answer that question and saying, yeah, I have met someone.
The first question is to remind you, because I rambled a bit, I'm sorry.
No, it's okay.
I'm just so interested in everything you presented today, so I have a lot of thoughts about it. The first question was more, do you have a plan for how to get the word out and get a bill created, get it pushed through, and make this a Colorado initiative?
That'd be great. It does look like we're missing some zeros out of our numbers there, because it's a very small number. You could buy a vehicle for that amount. And along those lines, I kind of, as just a little bit of a tangent, I just guess I should let you guys all know that we're looking for federal money, but there's private money that exists. Just in the way that the scholarships exist here, people want to see these types of programs initiated. So we looked into that as well, but we thought it would be more stable if we looked at the federal grant money. As far as getting word out there, we didn't take that into consideration at this point in our project, and the reason was we kind of looked at this as faceted, and this is just phase one. So this is very much an experiment to see if it would work, because it could very well fall flat on its face, either because of a lack of community support, because people want to actually have a psychiatrist, or there's resistance to seeking psychiatric services. That's possible as well. There's many stigma that we encountered in our research. We want to make sure that this succeeds first before we start promoting it. But not only succeeds, but becomes waterproof, and we can figure out where the holes are and we can start to plug them. Perhaps 2 is not enough. 2 providers part-time. Advertising would certainly be necessarily within the county itself. I meant to say that, I forgot that you'd have to tell people, because they're not going to come in and say, hey, I'd like to know how you can help me with the voices I'm hearing. They're not going to provide that. You need to make an environment for which they feel comfortable. So, thanks.
Anything from our esteemed faculty over here? Great job. Wonderful job. Thank you so much for being here.
Good job. You did a really good job.
Orationists.
Yeah, it's hard to, I think it's don't go too fast and say what you want to say. Yeah. And that's the biggest thing. I'm talking in public.
Right.
But I don't know.